Good afternoon. This is Dr. Kenneth Ellenbogen, and I have the privilege today to talk with Dr. Sanjay Kaul. Dr. Kaul is the director of the Cardiovascular Disease Training Program at Cedars-Sinai. He is a professor of medicine at the UCLA School of Medicine and at Cedars-Sinai. And today we're here to talk to Dr. Kaul and to learn from him about a very important paper that he published in the Journal of the American College of Cardiology. This paper was a meta-analysis of Dronedarone, comparing it to Amiodarone. And in this paper, Dr. Kaul looked at the clinical outcomes of patients treated with Dronedarone versus Amiodarone in terms of the benefits and risks of these two medications. Dr. Kaul, can you tell us a little bit about the methods you used to analyze this question?
Thank you. Good morning, Dr. Ellenbogen. Thank you for inviting me. First of all, we looked at two different endpoints. We looked at the antiarrhythmic efficacy of Dronedarone compared to placebo. And there have been about less than half a dozen trials that have looked at this. And what we found was that Dronedarone was twice as effective as placebo in maintaining sinus rhythm in patients with non-permanent atrial flutter or atrial fibrillation. And we also analyzed, at that time the study was not published but had been presented at several meetings, including at the FDA advisory panel, a study that directly compared Dronedarone versus Amiodarone called Dionysus. And the primary results in the Dionysus were that Dronedarone was half as effective as Amiodarone in suppressing recurrence of atrial flutter and atrial fibrillation. So that was the one part of our study. We also analyzed outcome trials with Dronedarone, and there have been two major outcome trials. The first one was called Andromeda, where Dronedarone was evaluated in high-risk patient populations, including patients with congestive heart failure. And that study was prematurely terminated because of an observation of increased mortality. And the second trial that we evaluated was the Athena study, upon which Dronedarone was approved by the FDA for prevention of cardiovascular hospitalization in patients with current or history of atrial fibrillation or atrial flutter. And so the Athena study was a positive study, and the primary endpoint of all-cause mortality and cardiovascular hospitalization was significantly reduced with Dronedarone therapy.
Now, what about the toxicity of these two agents? You've talked a little bit about efficacy. How do they compare both in the short term and the long term?
Well, there's only been one small study, the Dionysus study, and with very short follow-up that directly evaluated safety along with efficacy of Dronedarone versus Amiodarone. And Dronedarone was given in 400 milligrams twice daily dose versus Amiodarone in 200 milligram daily dose after a month of loading dose with 600 milligrams. And in that study, the safety profile appeared to be better with Dronedarone, about 20% better than Amiodarone, but it was not statistically significant. And it is conceivable that if they had enrolled a larger number of patients and followed the patients for a longer period of time, the differences would have been statistically significant. And the safety profile advantage of Dronedarone was primarily related to thyroid dysfunction, mostly hypothyroid disorder, and also some neurologic and ECG signs of prolonged QT and bradycardia. So in the Dionysus study, Dronedarone was half as effective as Amiodarone, but appeared to have a superior safety profile.
So, for a clinician, how does this come together? And there are a couple considerations. One is many people who have AFib, you're treating for 5 years, 10 years, 15 years. How would you put all this together in terms of what we know about these two agents and their relative efficacy and toxicities? Just sort of an overview, maybe summarizing the important take-home points for the clinician.
In my opinion, given the modest anti-arrhythmic efficacy of dronedarone relative to the gold standard, which is amiodarone, and lack of a clear-cut safety advantage that has been not demonstrated in the current trials, and the huge cost disadvantage. Remember, amiodarone is generic, whereas dronedarone costs nearly $9 a day. It's hard to make a case for using dronedarone as first-line therapy. Of course, as a clinician, each decision has to be individualized, and patient preferences and clinical judgment certainly play an important role in clinical decision-making. And I can see there are some patients who may actually accept an improved short-term tolerability over reduced efficacy as an acceptable trade-off, and those would be the patients where I can envision dronedarone to be initiated in these types of patients. But typically what I would say is that if patients respond to guideline-recommended first-line therapies, the class 1 agents such as propafenone, sotalol, or flecainide in the appropriate patients, but they have some tolerability issues with agents, then I would certainly consider the use of dronedarone, particularly a second line or a third line. But I would not use dronedarone as first line in these patients, and I certainly wouldn't use dronedarone in high-risk patients such as those with class 4 heart failure or patients with decompensated class 3 heart failure.
Well, I want to thank you very much for your overview of your paper. It was very useful and very thoughtful. Thank you very much.